Good evening, Dr. Phil here. Today we will be discussing on lung compliance, resistance, and volumes. Lung compliance. Lung compliance is defined as the change in lung volume per unit change in pressure, and the units are mil per cm H2O or liters per kilopascal. Components includes the compliance of the lung and compliance of the chest wall, as shown in this formula. 1 divided by C total equals to 1 divided by C chest plus 1 divided by C lung, where C total equals the total compliance, C chest equals the chest compliance, and C lung equals the lung compliance. The normal total compliance is 75 to 100 mils per cm H2O or 7.5 to 10 liters per kilopascal, and chest compliance normal range is 150 to 200 mils per cm H2O or 1.5 to 2 liters per kilopascal. Causes of decreased chest compliance includes ankylosing spondylitis, kyphoscoliosis, and circumferential thoracic burns, etc. The normal lung compliance is 150 to 200 mils per cm H2O or 1.5 to 2 liters per kilopascal, and it is determined by elastic properties of the pulmonary connective tissue and surface tension at the fluid-air interface within the alveoli. Effects of abnormal compliance. Abnormal compliance impairs the ability to have efficient gas exchange. When there is decreased compliance, lung expansion becomes difficult. The lungs are stiff and non-compliant. Volume change is small per unit pressure change. Decreased compliance is associated with increased work of breathing, refractory hypoxemia, changes in functional residual capacity. Functional residual capacity is increased, for example in acute asthma, where tissues are stretched to their elastic limit, greater pressures are needed to recruit alveoli, and ventilation at a high FRC has low compliance and high work of breathing. FRC can also decrease, such as in obesity, where there is reduced FRC and chest wall compliance due to restrictions from excessive adipose tissue. Decreased compliance is also associated with restrictive lung defects, reduced lung volumes, reduced minute ventilation, posture changes. Compliance is maximal in standing position and reduced in supine or head-down position. Age has no influence on compliance. Compensation is possible by increased respiratory rate. Increased compliance. Volume change is large per unit pressure change, and it is associated with incomplete exhalation due to lack of elastic recoil of the lungs, air trapping, decreased carbon dioxide elimination, airflow obstruction, increased FRC and TLC. Increased lung compliance can occur in emphysema. Static compliance is the compliance of the lung measured when all gas flow has ceased. The units are mils per cm H2O or liters per kPa. A pressure volume curve is obtained by applying distending pressures to the lung and measuring the increase in lung volume. The measurement of static compliance is made when there is no gas flow. And the formula is static compliance equals corrected expired tidal volume divided by plateau pressure minus P. Plateau pressure is the pressure needed to maintain lung inflation in the absence of airflow. In critically ill patients, static compliance is 40 to 60 mils per cm H2O and reflects the elastic properties of the lung and the chest wall. Static compliance is decreased in ARDS, atelectasis, tension pneumothorax, obesity, retained secretions, pulmonary edema, and other conditions. Dynamic compliance is the compliance of the lung measured during the respiratory cycle when gas flow is still ongoing, and the formula is dynamic compliance equals to corrected expired tidal volume divided by peak inspiratory pressure minus P. Peak inspiratory pressure is the pressure used to deliver the tidal volume by overcoming non-elastic and elastic resistance. In critically ill patients, dynamic compliance is 30 to 40 mils per cm H2O. It is lower in intubated patients and depends on the internal diameter of the ETT. Since airflow is present, airway resistance has an effect on dynamic compliance and reflects the airway resistance and the elastic properties of the lung and the chest wall, elastic resistance and non-elastic resistance. Dynamic compliance is decreased in situations such as bronchospasm, kinked ET tube, and airway obstruction. Typically, static compliance is higher than dynamic compliance because there is time for volume and pressure equilibration between the lung and the measuring system. The measured volume tends to increase and the measured pressure tends to decrease, both which act to increase compliance. The gradient of the line at any given point on the pressure-volume graph represents the compliance. Specific compliance is compliance divided by FRC. It is used to correct for the effects of lung volume on compliance. For example, neonates have equivalent specific compliance as a healthy adult. Changes in plateau pressure and peak inspiratory pressure in disease. Conditions causing changes in plateau pressure and static compliance causes similar changes in peak inspiratory pressure and dynamic compliance. For example, in atelectasis causes increase in plateau pressure and peak inspiratory pressure, and thus calculated dynamic and static compliance decreases. The graph shifts from A to B. Resolution of atelectasis causes decrease in plateau pressure and peak inspiratory pressure, and thus calculated dynamic and static compliance increases. In bronchospasm, when airflow resistance increases, peak inspiratory pressure increases, but plateau pressure is unchanged. As the peak inspiratory pressure increases, dynamic compliance decreases, and the plateau pressure is unchanged, therefore static compliance is unchanged. The graph shifts from A to B, and resolution of bronchospasm results in decrease in peak inspiratory pressure and increase in dynamic compliance. Pressure-volume loop. The pressure-volume curve. It is essentially a compliance loop. Since compliance equals to change in volume divided by change in pressure, the y-axis indicates the change in volume and x-axis indicates the change in pressure. Uses of the PV curve. It gives information on the patient's lung compliance. For example, shifting of the PV slope. It will shift towards pressure axis A when there is decreased compliance, and it will shift to volume axis B when there is increase in compliance. Shifting of the PV slope and the loop towards pressure axis A occurs in decreased compliance. Increased pressure is needed to deliver the same volume. A trend of compliance measurements is more useful than single measurements. We should not compare static with dynamic compliance measurements to avoid errors in interpretations. PV loop gives information on airway resistance. Increased bowing from the green lines to the blue lines suggests increased airflow resistance. Bowing from A1 to A2 indicates excessive inspiratory flow. Inspiratory flow exceeds the patient's tidal volume and inspiratory time requirement. Bowing from B1 to B2 signifies increase in expiratory flow resistance, such as bronchospasm. The curve can be used to set PEEP and to control ventilation. Limitations of the PV curve. The pressure-volume curve may oversimplify what is happening in the lung. Accurate dynamic compliance curves can be difficult to generate in diseased lungs. The PV curve represents the total rather than the separate lung units. Individual compliance of separate lung units may be very different, such as in ARDS, where 1/3 of the lung may remain normal. Hysteresis is the process in which a measurement or electrical signal differs according to whether the value is rising or falling, and this occurs in a PV curve. It implies absorption of energy, for example, due to friction. The area of the hysteresis loop represents the energy lost as elastic tissues stretch and then recoil due to viscous losses, and energy is also lost as airway resistance is being overcome, frictional losses. Positive pressure ventilation and decreased compliance. Constant pressure generators generate an increase in airway pressure, which then produces inspiratory flow. Inspiratory flow depends on compliance and resistance of the whole system, which includes the patient and the breathing circuit. There is an initial high flow into the lungs during the initial mouth alveoli pressure gradient. The flow decreases exponentially as the lung fills and pressure gradient narrows. In conditions of decreased compliance, alveolar pressure increases rapidly, the pressure differential decreases, inspiratory flow decreases, and there is decreased ventilation if the driving pressure or respiratory rate is not increased. Constant flow generators generate an incremental increase in flow rate to generate a tidal volume. Tidal volume is a product of flow rate and inspiratory time. Flow into the lungs is not affected by decreased lung compliance or increased airway resistance because the pressure of the driving source is much greater than the pressure in the airways. In conditions of decreased lung compliance, dangerously high airway pressures and alveolar pressures can occur during the delivery of an unchanged tidal volume in the face of decreasing lung compliance. Resistance is defined as the pressure change per unit change in flow. Units are cmH2O per liter per second or kPa per liter per second. Illustrated in this formula, RAW equals change in P over V, where RAW equals to airway resistance, change in P equals pressure change, which is peak inspiratory pressure minus plateau pressure, and V equals flow. Airway resistance occurs when airflow obstruction is present, and it is affected by the length, size, and patency of the airway, endotracheal tube, and the ventilator circuit. Airway resistance increases when there is increase in the length of the airway, decrease in the size of the airway, and decrease in the patency of the airway, and the obstruction of airflow may be due to changes inside the airway, such as the presence of secretions, changes in the wall of the airway, such as malignancy, and changes outside the airway, such as extraluminal compression by lymph nodes. The Hagen-Poiseuille equation, which is flow equals to pi p r to the power of 4 divided by 8 eta L, where P equals pressure drop along the tube, R equals radius of the tube, L equals length of the tube, and eta equals the viscosity of the fluid. The simplified Poiseuille's law, which is change in pressure equals to V divided by R to the power of 4, indicates that if the radius of the airway decreases by 50%, the driving pressure P to maintain the same airflow V must increase by a factor of 16 times. Normal airway resistance in healthy adults is 0.5 to 2.5 cmH2O per liter per second. Causes of increased airway resistance includes emphysema, chronic bronchitis, bronchiectasis, asthma, post-intubation obstruction, foreign body aspiration, endotracheal tube. Airway resistance increases the longer and the smaller the internal diameter of the ETT. Condensation in the ventilator circuit, croup, epiglottitis, bronchiolitis, etc. Time constant of a lung unit is the product of compliance and resistance. Time constant tau in seconds equals to compliance times resistance, and it is a measure of how quickly the lung unit will fill or empty. The time taken for the lung unit to inflate 63% of its volume is known as the time constant of a lung unit, and units of compliance and resistance cancel each other out except for seconds. In conditions where there is a long time constant, the lung unit either has increased compliance or increased resistance. The lung unit fills and empties slowly, and for a given pressure, the lung unit will have a higher volume. In conditions where there is a short time constant, there is either decrease in compliance or decrease in resistance. The lung unit fills and empties quickly, and for a given pressure, the lung unit will have smaller volumes. Clinical applications. The lung consists of many units of different time constants. There is a variety of filling and emptying velocities and volumes for all these lung units. For example, decreased compliance in ARDS results in short time constants. Increase in resistance in bronchial asthma leads to long time constants. These are my references. Thank you.